Once again, Bruna, it is a pleasure, an honor, and a privilege to, from King Khaled Hospital from Saudi Arabia, to have you again as a guest speaker.
Thank you so much.
Great honor. I know that you're very, very busy, but it's a honor, and it's great that you can share your time with us. So we're ready. Today's topic is a very important topic, which will be about how we can optimize our results with Toric IOL. So we're ready and we are on time, Bruna. Thank you so much.
Thank you so much, Jose Manuel. And I wanted to congratulate you on your initiative. This started, I think, almost a year ago. And now with everyone staying home, it's so common for us to see lectures from home, but at that time it wasn't. And it was amazing for me to be able to share my experience at the time on pediatric cataract with people from Saudi Arabia. And now we're seeing how you promoted this and people from all over the world join and learn. And it's so many rich lectures every week. So congratulations and thank you so much. It's a privilege and an honor to be here again. I'm going to talk today on optimizing toric IOL outcomes, and feel free to put the questions on the chat, whoever wants to make questions. It's always a pleasure to have discussions. So to start with this lecture, I wanted first to bring up some information on the prevalence of corneal astigmatism in our cataract patients. So we have an idea of how important it is for us to be speaking on toric IOLs. And on the same line, when we don't implant a toric IOL, but do a relaxing incision or target our astigmatism in any way that we want to minimize it. So when we look at our cataract patients, we see that about 6% or so, less than 10% of the patients have less than 50.5 diopters of corneal astigmatism, which in most parameters would be acceptable for patients to be left with less than 0.4 or 0.5 of astigmatism after surgery. But we see that 60% of patients have from half diopter to 1 diopter of corneal astigmatism, and almost 40% have over 1 diopter of corneal astigmatism. So when we're speaking on toric IOLs, corneal relaxing incision, managing astigmatism in cataract surgery as itself, we're speaking about a huge population of our cataract patients. So it's very important for us to have that in mind. And when we're looking at planning our cataract surgery, we always have to remember what's our target. What's our acceptable target of astigmatism, of refractive astigmatism after surgery? That usually is less than half diopters. Of course, when we say less than half diopters, is because above that, most papers already show that the astigmatism is visually significant. So the patients will notice this a lot. But this limit of half diopter was even more real and true, let's say 5 years ago. From 5 years ago to now, what we see is that we are promising much more to our patients, and we are generating much more expectations to them when we're talking about premium IOLs, premium surgeries, and emetropia. So when we're planning surgery now, actually the half diopter of astigmatism, it can be okay for most patients, but we're actually aiming at very close to 0, and we're going to see this throughout the lecture. So what is it necessary to optimize our toric IOL outcomes? I'm sure many of us many of you that are seeing this lecture already implant toric IOLs. And toric IOLs are wonderful IOLs in which we can get great results if we pay attention to small details. So it's very important for us to put some pieces together of a puzzle aiming at optimizing toric IOL outcomes. So the first tip, the first pearl that I want to mention is to have the routine of obtaining a corneal map besides the biometry. So here we have an example of an IOL Master 500 printout, where we can see that it gives me all data, all biometrical data, let's say, that we would need for a basic biometry. So we have the axial length, we have the flat and the steep keratometry, we have the amount of fill that we want to correct, we have the ACD, etc. So we have all the numbers. So many people can look at that and say, well, that's enough for me to calculate and plan my surgery and to decide if I'm going to use a Toric IOL or if I'm not going to use a Toric IOL. And what I want to highlight here is the importance of not only getting these numbers and trusting them with your heart, but also getting a topography or a tomography. Get a corneal map. Why? Because the same magnitude of astigmatism can be related to any of these maps below. So you will never know if you're 1 diopter of corneal astigmatism with the rule corneal astigmatism is with any of like a symmetrical astigmatism or regular astigmatism. It's very, very important for us to be combining our results from our biometer to a result of a corneal map. And it's very important not only for us to know about how precise and accurate is the number that's been measured, but also for us to know what are the real implications of that cornea with regards to how precise is our measurement and how precise is what should the patient expect with the visual prognosis, with regards to vision and the surgery. So let's say a patient has a corneal ectasia, a patient has keratoconus. The same amount of corneal astigmatism could be related with this patient that has keratoconus and another patient that has no corneal alteration. So it's very different when you detect preoperatively that that patient has a corneal disease or a corneal alteration. You explain to the patient that the patient has that alteration, that it could interfere in your planning and your calculations. Of course, we do everything when we have this information to minimize the error. Yeah, that's true. But knowing that the patient has a corneal disease is very, very important for us to take that into consideration in our planning, and also for the patient to know that beforehand. After surgery, it's very, very difficult for the patient to understand that whatever is found in his eyes wasn't caused by your surgery. So I always joke, and it's a very true joke, that it's very important for us to have at least 2 other exams when we're planning surgery in these patients with cataract. One is a corneal map, a topography or a tomography exam. And the number 2 is an OCT, a macular OCT, because it's very, very uncommon. We already published that. It's very common for patients to have subclinical alterations in the macula that after could have compromised the vision, or you could have made you choose a different IOL. And if you only find that alteration after surgery, you explain to the patient you didn't cause it, but for the patient, it's very, very hard for him or her to understand that that wasn't related to your surgery. So it's very important for us to have the routine of having a corneal map, having a macular OCT. And here it's very, very, very easy for everyone to understand how one magnitude and axis of astigmatism can be related to corneal maps that go from regular and symmetric to irregular corneas. So it's very, very important for us to have that in mind. A second point that's very important for us to mention is to have at least 2 devices providing similar measurements. So when we have the routine of having a biometry measurement and a corneal map, as we were talking before, the number 2 is already also okay. And why is that? When we have only one measurement, it's very hard for you to say that that's a very, that's an accurate measurement. But when you have 2 different exams that are based on 2 completely different technologies that say the same thing about a cornea, it's very hard for both of them to be wrong, especially if you're talking about 2 devices, 3 devices. The more devices that you measure and they're speaking the same language, let's say, the same amount of astigmatism, similar axis, you know that the chances of you being correct and precise are very, very high. So here we see an example of an IOL master and an OPD scan exam, and we see how it's both devices are measuring very similar magnitudes and astigmatism and axis of astigmatism, both for the right and for the left eye. We can also see the pattern of astigmatism and how this cornea of both eyes of this patient are wonderful. These are wonderful eyes for us to be implanting toric IOLs. A third point that's very, very important is to check the quality of the measurement. And that's very important for us when we're speaking about precision and accuracy of the measurements. So it's very different if we're trusting measurements like a corneal topography in which the exam was made, measuring all the points that it should measure. Whereas here on the right side of our screen, we see a measurement where there's a lot of places missing that should have been measured, and very different with regards to accuracy and precision. Our biometers, all of them, they have a way of saying and expressing also quality of measures. And it's very, very important for us to be paying attention to that also. Here we have an example of an IOL Master 500, and we see how the actual lengths are all very similar. The SNR, which is also a quality, an index for quality, is high, it's acceptable. And with regards to keratometry, the IOL Master 500 does 3 measurements of each eye. And when nothing appears in this box, it means that it was able to measure all the points that it does measure to obtain and derive the keratometry measurements. Compare with this other exam in the right, where we see that some in this box, that in this exam in the left is empty. And here on the exam on the right, we see circles and we see X's. So X's is a point where the device should have been measuring the curvature there, and it wasn't able to measure. So we see how in this eye, in this right eye, this whole area here wasn't measured. So this keratometry, this data for keratometry was all derived with the points that it could measure. Whereas here in this left eye, in one of the measures, it couldn't measure this area. In the second measurement, it couldn't measure this area. And in the third measurement, it couldn't measure this area here. So it's very important for us to take into consideration the quality of the exam. Most times we see that the exam has a lot of interference for, let's say, secondary to an important dry eye, and we can treat that and revert and get good quality of measurement, which is wonderful. Sometimes the quality of the exam is not so great because of an underlying disease, let's say a corneal degeneration that's important, and you can't really change that. In the cases that have no indication of surgery of the cornea before, or specific treatment of the corneal issue before, you can continue with your cataract surgery planning, but you take that into consideration. So it's not in every eye that you're going to be able to get 100% quality of the measurement. That's true. But if you can't get your perfect quality of measurement, you have to understand why you aren't able to do that. And if you can modify, let's say, is it a dry eye that you have to just compensate and the patient will have good measurement? Is it a pterygium that's interfering a lot in the measurement? So here we see in this topography how this patient has a pterygium that's big enough and interfering in this map. So we always have to understand if the quality of the measurement isn't good enough because of a factor that we can manage and change or not. In cases where we can't change, we just have to have that in mind and take that into consideration when we're planning the surgery and when we're talking to the patient and preparing him or her with regards to the expectations. A fourth factor, which is very, very important, is to factor in the posterior corneal astigmatism. Doug Koch in 2012 published a paper, which was not the first one that talked about posterior corneal astigmatism, but was the one that brought light to the topic. And after his paper, lots of groups from all over the world have been dedicated to posterior corneal astigmatism. So what they found in 2012 and published is that with regards to the posterior cornea, the mean posterior cornea of the population that they studied was 0.3 diopters. But look at this, the amount of the range of the astigmatism. It's very important to see how some patients almost have nothing of posterior corneal astigmatism, whereas others have up to 1.1 diopter of corneal astigmatism. When we're talking about premium surgeries, we would not accept an error, let's say like this, of 1 diopter of corneal astigmatism measured in the front of the cornea. So we can't just forget this parameter of the back of the cornea either. 9% of his eyes, of the eyes that they tested, had more than half diopters of posterior corneal astigmatism, also showing how important this factor is in our calculation. The posterior cornea is more curved vertically. It works as a negative lens. So it does result in against the rule astigmatism when we're talking about how it optically changes light. But how do I incorporate posterior corneal astigmatism? So there are so many ways of incorporating posterior corneal astigmatism nowadays. We can use devices that actually measure the posterior cornea. So the Galilei, the Pentacam, the IOL Master 700. We can use nomograms as the Baylor, that's Doug Koch's group. We can use toric calculators like the Barrett, the Panacea, the Johnson & Johnson's calculator, the Alphen's calculator, and many others. There are also coefficients of adjustments that we can use, the Abulafia-Koch formula. So there's many ways that we can do it. I continue using the Barrett calculator. I find it wonderful. My results are very good with it. So I continue using the Barrett calculator. We always have the hope that we can actually measure the posterior corneal astigmatism and use that number in every eye. But the studies up until now aren't convincing that we should be doing that at this point. But we really hope the technology advances in that way. The Barrett toric calculator, speaking a little bit more about it, it is free access, so anyone can access it for free in the ASCRS site or in the Asia Pacific site. Here is let's say the screenshot of the calculator so that we can go over it for those that have not been using it lately. It's very, very user-friendly. So you usually have to specify the eye that you're planning the surgery for. Here you can choose the lens that you're going to implant. If you have personalized the constant and you want to use your personal constant, you can. There's no problem, and you can put here or here. But if you're using the optimized lens constant that has been optimized by the device manufacturer, here's where you're going to find a list of all of the lenses. Then we come here to this place of the calculator where you have to put the data for the flat keratometry, the steep keratometry, the axial length, the optical ACD, what's your target refraction, the amount of corneal incision of surgically induced astigmatism, where you're going to do your incision, lens thickness, and white to white if you also have that data. After you do that, you press here calculate, and then you put Toric IOL. And when you do that, you come to this other screen where you see all the calculations done. So here we see, if we put, here is an example for the Johnson & Johnson lens, the ZCT. And we can see that if I put a ZCT 2 to 5, the residual astigmatism that's predicted would be this amount of residual astigmatism. If I choose a ZCT 300, it expects of getting a 0.03 residual cylinder at 84. If I put this other one, the ZCT 375, the expected residual fill would be of 0.55. So in this area below, you can choose the different amount of toricity that you want to use in the patient. Usually we choose the one closest to 0 without flipping the axis. And here in this place above the calculator, we see where the toricity is already automatically, the calculator already automatically puts the one that's closest to 0 from the table below. But if for any reason the surgeon wants to put another one, you just change in your planning and when you're asking for the lens. But the top here is to see the amount also of the sphere of the lens that we're going to use. So we see how in this patient, for example, if I implant a 22.5 diopter ZCT 300, the amount of spherical equivalent that's expected after surgery is 0.24 with a 0.03 cil of residual astigmatism. Here we see where we're planning our incision for this patient that we put in the calculator in the screen before, and where it suggests us to align this lens. So it's suggesting us to align the lens at 174 degrees. And below here, we see a summary of all what we were seeing in the other parts of the calculator. So the calculator recommended, since we had put as target refraction 0 emetropia, it recommended a 22.5 diopter ZCT 300, which we had already seen here, with the axis of 174 degrees of alignment. The Toric calculator enables us of using up to 3 keratometries if we want to do that, which is a very interesting tool, let's say. So you just need to come here and it opens this other screen where you can put, let's say, 1 keratometry that you obtained with your IOL master, a second keratometry which you obtained with a topographer A, a third keratometry with a topographer B, or a tomographer, different measurements that you have obtained. There are studies that have been shown that this is a very promising tool, but what we see now is that it changes very little what we have been doing. So here's an example of the same patient in which I inputted 1 keratometry data, and here where I inputted 3 keratometry data. And you can easily see that here I put more than 1 keratometry to calculate, because here in this box, red box that I pointed out, we see that the mean keratometry of what was measured with the IOL master and 2 topographers. So we see how this changed very little where we're going to align this lens, but it's a tool that the Barrett's calculator already gives us, and that in a near future, we hope that it will be letting us have even better results. Another tool that the Barrett calculator has been providing us is the possibility of using measured posterior corneal astigmatism. Here we can change. So we can use the predicted posterior corneal astigmatism or the actual measured posterior corneal astigmatism. When we click here to use the measured posterior corneal astigmatism, this opens and we can put how we measured the posterior corneal astigmatism. So if you're using your IOL Master 700, your Galilei, your Pentacam, and then you put here the data that was actually measured. Some doctors have already started using this, but most papers haven't shown superiority with regards to using the regular predicted posterior corneal astigmatism. So what we see is that the tool is ready for us to use the measured posterior corneal astigmatism, but we're still waiting for the devices that actually measure the posterior corneal astigmatism to improve a little bit more. We've been talking in these last 30 minutes on corneal astigmatism. So measured corneal astigmatism from the anterior cornea, incorporating the posterior corneal astigmatism, but it's very, very important for us to remember the induced astigmatism also. Both of these are, the corneal astigmatism and the induced astigmatism are very important when we're planning our surgery. So how to calculate the induced astigmatism? We can use the Dr. Hill's website, which very easily calculates the the induced astigmatism that we induce in our surgery if we want to have a number personalized. Before many years ago, we talked about mean induced astigmatism. So we were talking about, let's say, we do 30 patients with incision temporarily, let's say, and you get the same device to measure their cornea preoperatively, and at least 3 weeks postoperatively, another measurement. And then we would compare the amount of astigmatism, and we would get a mean. So let's say we would say, oh, my mean astigmatism that I induce in my surgery is 0.3 or 0.4. And when we were talking about mean, we were considering the astigmatism as having just the magnitude. We were forgetting all about the axis. We weren't talking about astigmatism as a vector, but as a magnitude. After, the next step was to change from the mean to the median. And we improved a little on the results when we incorporated the median of the astigmatism, but we were also talking just about the magnitude of astigmatism. Lately, we had some years, from some years ago until now, we have changed completely that approach. And we now look at the astigmatism not only as magnitude, but also from magnitude and meridian, so axis. We look at the astigmatism as a vector. And this is a very, very important difference. Why? Because when we're looking at astigmatism as a vector, let's say you induce in a patient 0.3 diopter at 90 degrees. In a second patient, you induce 0.3 diopter at 180 degrees. So your amount of induced astigmatism, it's not 0.3, it's actually a centroid of 0. So when we changed the idea of mean and median to centroid, it changed completely the amount of induced astigmatism that we're considering. Most of the doctors now, let's say to an incision of 2.2, are considering 0.8 or 1 diopter or 0.1 diopter. I'm sorry, 0.08 or 0.1 diopter of induced astigmatism. When you're considering a larger incision of 2.4 or 2.7, that would increase to like 0.15 or 0.2. But those are very small numbers when compared to the ones that we were used to using when we were talking about mean astigmatism. So when we started talking about centroid, the amount of astigmatism that we're considering as induced astigmatism, it's much smaller than when we previously were considering mean or median of the magnitude. What should be my aim of residual astigmatism? When we were talking about the Toric calculator, we talked about this part of the calculator here. And when we were beginning the lecture, I was talking about 0.5 diopter of astigmatism being the cutoff point where patients usually start noticing the astigmatism changing their vision. But we shouldn't be aiming, let's say some doctors could understand that I was saying for you to aim at 0.5 diopters here, half diopters of residual corneal astigmatism. And that's not true. Starting at 0.5 diopters of corneal astigmatism, the papers show that the astigmatism will influence a lot on the patient's vision. That's true. But when we're planning surgery, we should aim at the minimum amount of astigmatism possible, remembering not to flip the patient's axis. I usually accept the numbers here up to 0.1 diopters of astigmatism, residual astigmatism that's predicted. And when that's larger, I usually shift a little bit the place where I do my main incision. So this is important for us to have the minimum amount of astigmatism after surgery, and that for sure is related to patient's satisfaction. So remember the 0.5 diopters of astigmatism. It was something that was true for the last years, But when we're talking about premium IOLs and patients with more and more expectation of being glasses independent with wonderful vision, and patients that are so active right now, we see that the population of patients with cataract nowadays is totally different than 20 years ago or 10 years ago. We have patients that are completely active as if they were 40 years old or 30 years old. So the quality of vision is very, very important. Instead of wanting to leave them with half diopter and aiming at that after surgery, we should be aiming at leaving them 0.1 diopters, because if that's a little bit more after surgery, it will still be very small and not interfere in their quality of vision. So, okay, I chose the Toric IOL. I had all the care in getting the biometry, at least one map of my cornea. I checked that the quality of the map and the biometry are good. I had all the care in choosing and planning my surgery. So it's the day of the surgery. What should I be taking care of? What should I be focusing and caution? There are 2 points that are very, very important. The point number one is with regards to the IOL alignment. And point number 2 is in maintaining the IOL aligned. With regards to the IOL alignment, there are many ways that we could mark the meridian. So we can use the slit lamp, we can use pendulums, automated systems. I tried and we tested in our institution the automated systems, but I went back and using the slit lamp, which works wonderfully. So it is important for the slit lamp to have this dial if you're using a slit lamp. And this dial enables us to know in which meridian our slit is aligned, and that's how we use it. So one thing that's very, very important when we're using the slit lamp to mark the axis is to have it completely aligned when we're going to do the marking. And then you just change this so that the slit of your slit lamp is aligned with regards to the meridian that you want to mark. If you have a slit lamp that the light goes beyond the limbus, it's even easier. But if your slit lamp is just smaller like this, it's usually enough. Our routine here is to mark to do the marks for the Toric IOL close to the pupil. That's something that I learned with my dad, and I love this tip that he has, because we also use a lot of femtosecond laser here in our patients. So we all know that for the femtosecond laser patients, we have to do two markings also to compensate for cyclotorsion. So sometimes you have the 0, 1 to 80 degree marked to compensate the cyclotortion of your femtosecond laser. And you have, for example, an IOL that should be aligned at 175 or 170 degrees. So in order for us to not get confused in which marking is for the femtosecond laser, which marking is for the Toric IOL, we have the standard of always use the routine of always marking the 2 marks for the Toric lenses close to the pupil, which even makes it easier for us to know where to align it. And we do the 2 markings for the laser by the limbus. So this makes us never get confused which marking is for which technology. Here we see a lens where we're seeing the 2 marks on the cornea that I did on the slit lamp, and we see the 3 dots here and the 3 dots here that are for us to align our Toric IOL. Here it's perfectly aligned. In some patients, the lens doesn't align perfectly as we see it here on the picture, but it aligns parallel to my marks. If the lens is the marks in the lens saying where the meridian of the lens, the axis of that IOL is parallel to the marks that you did on the cornea, that's enough. And it's okay for you to leave the lens there. A second point that's very, very important is to maintain the IOL in the correct alignment. And here I wanted to point out 3 things. So first is for us to obtain an adequate size of the capsule rhexis. That's very, very important to keep our Toric IOL exactly where we left it. It's very, very important also for us to have the routine of aspirating the OVD from behind the lens. And I always tell our residents to start doing that in patients where you're implanting a monofocal IOL, where there's no actual expectation of being glasses independent for far, as in when we're using a toric IOL, or far and near when we're using a multifocal toric IOL. But start trying and getting perfection in aspirating the OVD from behind the lens in cases that are not so, that you didn't increase the expectation of the patient so much. When you get perfection in that in your monofocal patients, and then you start doing that in all of your other patients too, in your toric IOL patients and in your multifocal. This talk is more when you're going to start implanting toric IOLs. So it's very important for you to be already very comfortable in aspirating your OVD, and do that beforehand with your patients that are already in which you're implanting monofocal lenses, so that once you're going to start implanting toric IOLs, you're very, very comfortable in aspirating the OVD from behind the lens with no difficulty. A third point that's very, very important is for you to pressurize the eye at the end of surgery. And it's very important for you to pressurize the end of surgery and maintain it pressurized after surgery. So let's say you have an eye that have a very long axial length, or an eye that have, let's say, RK incisions. In these eyes, I usually, besides hydrating the cornea, I do a suture with pano nylon to make sure that I won't have decompressions that are very slight usually, but that can shift a little bit my toric IOL from place and then change my results. So my dad always says, and I love this saying, that he never regrets a suture that he put in place during surgery, but he has already regretted sutures that he have in place. So if you have an eye that you know that maybe you won't be able to make sure that the pressurization of the anterior chamber will be maintained after surgery, just put in a suture. You're going to lose 5 seconds of your time, and that will prevent any headache in the postoperative period. It's very, very important for us to remember, we all know this table here, which says that every 1 degree of lens misalignment makes us lose 3.3% of toric correction. But it's very important to understand that when we rotate a toric lens, when it's misaligned, it's not only that we lose the amount of toric correction, we also induce astigmatism in another axis that the patient wasn't used to. So if we have 30 degrees of a lens misaligned, it doesn't mean that we're going to have zero amount of corneal astigmatism compensated. You're going to have the amount of astigmatism that should be compensated flipped in another axis that the patient isn't used to. So this is how really a result that we don't want to have. So it's very, very important, all the planning of the surgery, so that we can plan for the ideal amount of toricity to be implanted and corrected, the sphere of the lens, where to place it. But it's also very important, the surgery intraoperatively, so that we have a chance of having a minimum amount of risk of this lens to rotate after the surgery. And this is what I wanted to bring up and discuss with you. I'm going to stop sharing my screen here so that I can go to the chat. If you have any questions, I'm very gladly here to answer.
Thank you so much, Bruna, for an excellent presentation. And you pointed out many aspects that are very important for you when you're going to decide if you're going to use a toric IOL or not. My recommendations are almost the same as yours. Always look for 2 principles to see if you got the same amount of astigmatism and the same meridian. This is very, very important. Second, the pre-op evaluation is very important for these patients. Make sure that you select the right patient for the surgery. And the other thing, for premium IOLs, maybe for monofocal IOLs, I can correct more than 1 diopter, usually, with a toric IOL. But if I have a patient that I have a schedule for premium IOL, if the patient have 0.5 or more, I will correct that astigmatism, because that astigmatism will make a suboptimal result if I don't correct it?
Yeah, I'm glad you brought that up. It's always interesting to see how different doctors, what are their routines with regards to the amount of astigmatism that they start planning a toric IOL, what they do below that amount of astigmatism. So what I have as a cutoff is that usually when I measure more than, let's say, 0.6 or 0.7 diopters of against the rule of astigmatism, 0.7 diopters of with the rule of astigmatism, in these eyes, I usually implant a toric IOL. In patients that have, let's say, from 0.3 to 0.6 of astigmatism, I usually do my incision. My routine is to do my incision in the steep meridian, and then I also do a relaxing incision 180 degrees from that. So I always aim at leaving my patients with the least amount of astigmatism possible after surgery without flipping the axis. But that's usually my cutoff point. So before I would use the cutoff point of 1 diopter, but I actually, from like 3 years ago until now, I changed that to a lower limit of astigmatism, in which I start implanting the toric lenses with great results. Here in Brazil, we have lower adds of lower amount of toricity that we can correct with the toric IOLs. That's a little different from the US. I'm not sure how it is in your country there, but that having smaller amount of toricity that we can correct with toric IOLs have improved the results in these patients. And when they have a toricity that's from like 0.3 to 0.6, I usually just combine with my incision in the meridian that's steeper, a relaxing incision with the femtosecond laser.
Great, great.
Yeah.
Absolutely agree with you. So now, Bruna, we're ready for the question. So far, I see that you have 12 questions on the chat. Let's see how many of them we can answer. Please go ahead and start answering those questions, please.
Perfect. So the first one is my preferred method to mark the axis. I tried 2 different automated marking systems from different brands, and I went back and using my slit lamp. So that's the way I prefer, and I have great results. I don't really see the need now to go automated way of marking, but that's very, very personal. So I do my markings as I showed in the presentation. So I already do my slit lamp and place the slit of my slit lamp on the axis that I want to align my lens. Some doctors will use the slit lamp to mark, let's say, the 0-180, and then use another instrument in the surgery to align to the 0-180 and then mark your axis of alignment. I find that this method can work for some doctors, but it's an extra step that doesn't improve accuracy. So I already use my slit lamp to mark exactly where I want to align the lens, avoiding another step that could potentially increase the error in alignment. So my preferred method is using the slit lamp to already mark exactly where I want to align my lens. And I only mark the 0-180 to compensate for the cyclotorsion for the femtosecond laser. What is an SNR acceptable? SNR? What's SNR?
Which question are you in? Because we have so many questions here.
Murilo Domingues.
I'm seeing that the other one. You are on
Murilo,
the chat.
if you can tell me what's SNR, I can.
Let me see.
I'm not sure if you.
Where are you? Let me go. You start from the beginning. Let's see.
Yeah, I started in the beginning. So Murilo also asked, in the Barrett, can I use the total?
This is that you mentioned for quality on the IOL.
Oh, okay, for the IOL master.
Yeah.
Yes. So that's an interesting question. It's very hard for us to have a good quality measurement for the IOL Master 500, and you have, let's say, less than 100 of SNR. When you see lower SNRs, usually, let's say, in this patient, I got an SNR of, let's say, 10 or 20 or 40, which is considered very low. Usually we see that in patients that have a very dense cataract. And then you have to see with that in mind if you're going to trust that measurement or not. But usually in patients that don't have dense cataract, it's very, very hard to get low SNRs if the exam was done correctly, okay?
You know, you can also go, so we will be equal for everybody. You can also, because you're on the chat right now, but if you go to the Q&A questions and answer, you will see so many questions.
Oh, I'm sorry. I was
go to that one.
The chat.
There is a good question for our friend Christian from Switzerland there. And we have another one from one of our consultants from here, from King Khaled.
Oh, it doesn't open for me here. Can you, the Q&A doesn't open for me here.
There's one from Christian, our regard from him. It's a little bit far away from us, enjoying his quarantine there in Switzerland. What about the use of the eye trace? Angle of alignment and exclusion of toric IOL before surgery?
Yeah, that's a very good question. I worked in eye trace when I was at Baylor, but we actually didn't incorporate that in our routine. So I haven't used that. I don't have experience with the eye trace right now. The devices that I use routinely are the IOL Master 700, the topographer OPD, and the Galilei. Those are usually the devices that I use. And although I mentioned using at least 2 devices, what I find is when a cornea is very special, let's put it that way. So you see that for some reason there's an irregularity or let's say it's a post-refractive surgery patient or post-RK, and you want to be more precise, and it's a cornea that's possibly more difficult for the devices to obtain very, very good measurements. I usually tend to measure with more than 3 devices. So I usually use the second topographer beside the OPD and then compare, let's say, these four numbers to see if I'm in the right way of planning or not. Usually in corneas that are irregular or that have something that makes them hard to measure and to obtain good measurements, obtaining 3 or 4 measurements from different technologies make us more with a greater chances of getting it right or planning right. So that's my routine. What's my preferred toric IOL and why? That's a very good question. I actually like all toric IOLs. I just haven't used the plate toric IOLs, so I can't really talk about them. But I have used and like a lot Alcon toric IOL, Johnson & Johnson toric IOL, and Rayner also. Those are the 3 toric IOLs that I have implanted, and I like all of them very similarly. Which cases of keratoconus would I implant a toric IOL? That's a very, very good question. So some things that I take into consideration when I see a patient with keratoconus to decide if the patient if I'm going to implant a toric IOL or not, is first, if the patient is dependent on contact lenses before the surgery, if he or she is dependent on contact lenses before the surgery to compensate for their keratoconus, and then this patient will get a monofocal IOL and continue with rigid contact lens after surgery. But if the patient does not depend on contact lenses before surgery, if he or she has a stable keratoconus, mild to moderate keratoconus by the topography measurement, and without any scar in the cornea. And when I look at the maps, the central 3 millimeter of the corneal topography, if I see that there is a certain regularity in that astigmatism that I can use to calculate the toric IOL, then I go forward and I use toric IOL. I have wonderful results using toric IOL in eyes with keratoconus, but I really select the patients carefully, taking into consideration if he or she is dependent on contact lenses, how regular is the central 3 millimeters of his cornea, and the grade of keratoconus. When you use predicted posterior astigmatism on Barrett, how does the website predict it? Graham Barrett uses a sample from the population, let's say very similar to the data that Koch brought up in his papers, to incorporate and to define the predicted posterior astigmatism. So it's a population-based number. When we use predicted posterior astigmatism from the Barrett calculator, it's a population-based number and not a number measured for each patient. Rui Freitas, the idea of 30% of rotation of toric IOL has been discussed in a recent ESCRS editorial and many scientific documents before that. If we have, this is a wonderful point that Ahmed mentioned here. If we have a patient with against the rule astigmatism, is it acceptable to shift the axis to with the rule astigmatism? So some doctors think that. So since we know that when we age, when the population age, we see a change, a shift in with the rule astigmatism to against the rule astigmatism, and an increase in this against the rule astigmatism over time. Some doctors do defend on planning the surgery to leave the patients with a little bit amount of with the rule astigmatism to compensate for that shift over time. I plan my surgery for the patient to have the best result and to enjoy the best results in the few weeks following surgery, because we never know how much time we're going to live. So I never plan for, let's say, a year, 5 years, 10 years after surgery, but some doctors do, and that's not wrong. I just think it's a personal approach. So I really avoid flipping the axis, but it's not wrong. And we will see a lot of colleagues that will flip a little the axis to with the rule, leaving a little bit amount of with the rule astigmatism, considering that there will be a flip over time to against the rule.
This is a nice question. This is the last one for question and answer, then we go back to the chat. This is from Saya Stanias. She was a consultant here at Kekesh. Can you answer this one, Bruna, please?
If I have experience with leaving an air bubble to avoid axis rotation, especially in long axial length eyes? No. In these eyes, my routine is actually just I leave the lens aligned. As routinely, I will do a movement of like pressing the lens against the posterior capsule. But what I really do is taking care that the chamber is well maintained and stable after surgery. So I always put in a suture in the main wound in these patients that have long axial length. That's my routine. Do you put an air bubble in these eyes, Jose Manuel?
No.
Is that your experience?
No, not experience with that. It's not my routine.
Okay, yeah. So you want to go back for
to the chat? Yes.
To the chat. What Ahmad? What about trifocal IOL and astigmatism? When we're talking about trifocal IOLs, extended depth of focus IOLs, etc., and astigmatism, it's even more important for us to have in mind and aim at leaving the patient with the minimum possible astigmatism, residual astigmatism after surgery. It's very, very important because we see that residual astigmatism, and some studies have proven that, compromise more the quality of vision than, let's say, a residual spherical refractive surprise after surgery. So it's very, very important for us to take into consideration that when we're planning a trifocal toric IOL. Diego asked about keratoconus, and I think we already answered that. How to minimize movement from the IOL while removing OVD? That's a wonderful question. My routine is, so I implanted the lens and it's totally out of alignment. So what I do is, while I lift the lens a little bit, aspirate the OVD. I'm not worried about axis alignment still at this point, but I'm removing the OVD from the posterior, from the back of the lens. And then I remove the OVD from all the anterior part of the eye. And before going out of the eye, at that point, what I do is I use the tip of my INA to place the lens at around 10 degrees or 5 degrees before what I want to actually leave it at the end of my surgery. So with the tip of my INA, after I already remove the OVD from behind the lens and from above the lens, I will align the lens almost where I want to leave it at the end of the surgery, but around 5 or 10 degrees before. And then when I remove my INA tip, I go with the cannula with BSS in my secondary incision, and injecting the BSS, I do the gentle adjustment of that 5 to 10 degrees that was still to be made. And this way, you don't miss the alignment. Let's say passes a lot from where you want to align and you have to rotate it. No. So I always do this trick with the INA tip and the cannula with the BSS, and that way it doesn't really change a lot. You have a lot of control to where the lens is going. And when I'm removing the OVD, that's not something that I'm keeping in mind, because after I remove my OVD from behind and from above the lens when I'm going to start to really align the lens.
Bruna, let me ask you one question. What is your, let's say that you make the surgery and you find some rotation of the lens that compromise the result. What will be your time limit to realign that IOL?
That's a very good question. Up until now, I only had one patient that had a lens rotation. And it was interesting because he had a big amount of astigmatism, and the first eye was right on, wonderful. He was the happiest person ever. On the second eye, the first day post-operatively, he was wonderful, very happy. 1 week after when I saw him, the lens had rotated, and he went into my office and he's like, "Doctor, something's wrong. I see better than before surgery, but not as well as the other eye. Something went wrong." And when I saw that, and I saw that his lens had rotated, it's very easy first for us to understand, because sometimes it happens on the first day post-operative. And for you to know if you chose the wrong lens or implanted the wrong lens, let's say someone handed to you a wrong lens and for some reason you didn't do the timeout and you didn't check, this is one situation. Whereas when the lens rotates, for you to differentiate these two things, it's very, very easy. If you have a refraction in which the spherical equivalent of that refraction is close to zero, close to what you planned, then the lens rotated. It's not a wrong lens that was implanted. I usually go in this case, I went in as soon as he came into my office. So 1 week after surgery, I did not wait longer because he didn't have any underlying condition that would make the lens rotate again. Some colleagues would wait longer and say that they wait, let's say, for a month or 2 months, so that the lens, the capsular bag's already a little bit fibrosed and then induces more friction with the lens. I usually, in this patient, that was the only one, I chose to go in and already solve it, since the patient was unhappy and he didn't have anything that underlying condition that would favor to rotate again. One very, very interesting technique that I find, and if a lens in my hands rotated again for, let's say, a long axial length, that can happen, is to do a reverse capture of the lens, of the optic of the lens. I'm not sure if you guys have seen it, but I think it's a very, very interesting technique where, let's say, the patient has a long axial length and also a bigger bag. And for that reason, the lens of Toric IOL rotated, we can always align it in the axis that we want and reverse capture that optic in our rexes of the good size rexes. And that way the lens is exactly where we want to leave it. I thought that's a great technique that can be used in these cases, let's say with long axial length.
That's correct. And that's what is very important in these cases, to have a regular and a center capsular rectus in these patients.
Yes.
This is one of the beauties of the femtosecond laser.
That's true. That's very, very true.
There is
you
one
always know
here, Bruna, from one of our fellows, an F2. You're lucky today that he's doing only one question. He usually made more than one at the same time. He says some experts use the ciliary vessels at 3 and 9 o'clock as a marking reference. What do you think about it?
I think it's interesting, and I think that, in my opinion, sir, not one technique works for everyone. I always tell my residents that, let's say there's no one technique for fracturing the nucleus, the cataract, that's wonderful and everyone should use. It's what works in my hands, in your hands, etc. So in my hands and in my experience, the slit lamp works wonderfully, but I have wonderful colleagues with a lot of experience that do use the vessels as marking. But then we also have to have I'm not remembering the name in Portuguese, transferidor. So I'm not sure if you remember that in Spanish. So you always have to have, let's say you take into consideration the vessels at 9 and 3, or you mark at the slit lamp 9 and 3. You always have to have the other instrument to intraoperatively mark where you want to align that lens. So it's one extra step that's prone to error. So I really avoid any extra steps that are not going to increase my accuracy, but it can be used.
Excellent. So I think we got more time to answer a couple more questions, Bruna. Just pick it up if you want.
Mohammed asked about CTR with rotating toric IOL, which is another technique. We recently had that discussion in the Alexa online platform, where anyone can join. You are all welcome to join. So Latin American Association of Cataract and Refractive Surgery has an online platform where we're always discussing cases and debating cases. And one of the topics that came up was this. And let's say long eyes, where we have a toric IOL that rotated. The discussion was, most of us have had the experience of putting in a CTR to decrease the chances of this lens to rotate. And then one of the doctors talked about the reverse optic capture, but using the CTR is a possible technique. And it's interesting to see that some colleagues are already using it routinely when they see that the patient has a long axial length and needs a toric IOL implantation. It's not the routine in most centers, but some colleagues for specific patients have already chosen to not wait for the lens to rotate, but use it preventively. Centroid concept in SINA and the surgically induced astigmatism. That's what I explained previously in the slide. So when we talk about centroid, you always think about the astigmatism as a vector, which it is, and not as just a magnitude. So it's very interesting when we see the amount of surgically induced astigmatism that we're considering nowadays in our surgeries, which is 0.1, 0.08, some doctors 1.2. It really depends on the amount, on how big your incision is and where you place it. But it's very, very different than the numbers when we were talking about magnitude, mean of magnitude or median of magnitude. It's very important to mention the size of the incision. So when we're talking about size of the incision, it's wonderful for us to try to operate and be more familiarized and operating in smaller incisions. That's very, very true. But we have to understand that there's a limit for everyone. And it's very important for us to remember that worse than doing a bigger incision, let's say a 2.7 incision, is to do a smaller incision and with your instruments and intraoperatively stretch a lot that incision. So what I always like to point out is it's very important for each one of us to know what's the smallest size of incision that we're comfortable in operating, in which we don't stress that incision too much in implanting the lens and in manipulating the nucleus, etc. Because when you stretch the incision, then you induce astigmatism in a way that we don't really control it. So it's not very good for planning our surgeries. Ahmed is asking if I would keep my patient in a strict supine position for 1 to 2 hours in the recovery room. No. My patient, I operate with topical anesthesia. The patient stands, like he's laying down, he sits up, and he goes to the recovery room already sitting down. So he doesn't stay, I don't know, 5-10 minutes. He stays 5-10 minutes after surgery, lying down, just the time for us, 5 minutes, just the time for us to get everything in the room. The nurse comes for him and he goes and he's already in the sitting position. We don't really have our patients in the supine position, and I don't see a need for that still, yeah. And have I used intraoperative aberrometers? I have used the Aura previously. And although it is a very interesting concept, in most patients, it didn't really change what we were already planning. Where I really think we need to improve in biometry is in, let's say, post-RKI, in which the Aura wasn't giving us very precise results and very trustful results. So we ended up not buying it here. If we should consider angle kappa prior to toric IOL, I don't look at the angle kappa before indicating a toric IOL. Do you, Jose Manuel?
Say that again. I couldn't hear you. I was reading the questions.
If you look at the angle kappa from every patient before indicating a toric IOL.
No.
And one other concept that's very, very interesting is remember that toric IOL will correct, let's say, the amount of toricity that's regular. So let's say a patient that has a macular alteration. This is important for us to discover before surgery so that you explain to the patient. But if the patient has an amount of astigmatism that should be corrected with a toric IOL, the presence of macular alteration does not interfere with the indication of a toric IOL. Actually, by correcting the amount of astigmatism inside the eye will actually give him or her even a better quality of vision than correcting it if it's an important amount of astigmatism in his glasses. So when we talk about macular OCT, it's very, very important for us when we're talking about premium lenses. It really contraindicates lenses when we're talking about presbyopia. It's very, very important for us to have the exam so that we can plan our surgeries accordingly, but it doesn't contraindicate a toric lens, the presence of macular disease.
Totally agree with you in that. If for premium IOLs, if we have a patient with a macular problem, we don't use premium IOLs, but we can use toric IOLs. And if we have a patient with an advanced diabetic retinopathy with a macular problem, we don't recommend the use of premium IOLs as well.
Perfect. And here a question, if residual astigmatism, I understood the question this way. I'm not sure if that's what the person intended. So if residual astigmatism, if I rotate the axis, I always take a lot of time, which once you have your routine well established, it's not a lot of time, but I'm always very careful planning the surgery and intraoperatively so that my surgical result is as accurate as possible. Of course, sometimes we still have refractive surprises, and that's why technology is evolving, and we're always seeing lots of papers being published with different technologies and different ways of doing our calculations. But if I understood your question, is if I see a residual astigmatism, if I go back to rotate the lens. And my approach is, if that amount of astigmatism is bothering the patient, yes. If not, I don't see a need for another surgery in which you're exposing the patient, even with all the care that we have, to another surgery, risk of endophthalmitis and everything. So I really think it only makes sense if the patient is bothered and the amount of residual astigmatism is important. and if I use Purkinje image or corneal marks for Toric IOL alignment, I use the corneal marks as I showed you earlier, remembering that not always we can align the IOL marks exactly where you did your corneal marks. Sometimes the corneal marks are the IOL marks are parallel to your corneal marks, and that's okay because it shows that you're in the same axis, in the same meridian. If I notice rotation 2 months after surgery, do you recommend doing laser correction or rotating the IOL? I really think it depends on the doctor. I don't do the LASIK or PRK, but we have many colleagues in our institution that do, so it would be okay to send them. It really depends on the case, on the patient. I am more in the opinion of getting it solved where it's originating, and I would use just the IOL rotation, but there are some colleagues that would do laser vision correction surgery on top of it to compensate for that residual astigmatism. But if the amount of astigmatism that's appearing in my patient's refraction is due to an IOL that rotated, I really think it's very easy to go back and just rotate the lens in place. I wouldn't do a second procedure, but there are some colleagues that do choose to correct it doing a PRK, and that's okay. I really think it's a personal choice, but I always try to solve where the problem is originating. It's different than, let's say you're planning a surgery and you plan completely doing all the steps correctly, you do the surgery and you have a refractive surprise. You go back and you look at your calculation and you don't find what's causing this refractive surprise. In this case, a PRK makes totally sense for me, but that's like the exception of the exception. If you find it that the refractive surprise is due to a lens that rotated, it's very easy to go back and put it back in place.
That's correct.
And here in the Barrett, can I use the total posterior astigmatism on the Galilei? Is it comparable to the IOL Master 700 posterior astigmatism? I wouldn't use the total posterior astigmatism. I use usually the posterior astigmatism. If you want, so on my papers, not on my practice. I haven't seen the advantage of using it on a day-to-day basis in my patients. But what I see is that it is promising, and we really hope that these measurements will get to the point where we can actually measure and do the calculation specific to that patient, but it's still not there. We still need to improve on the technologies for that. But I think it's something that's very promising, and to have the calculator or the Barrett calculator already ready to receive the numbers, it's wonderful, because once we get the technology there for the measurements, it's already ready. The tool's already ready. And if the posterior astigmatism of the Galilei is comparable to the IOL Master 700, I haven't analyzed the data this way, so I really can't say. Let's see more.
Let's see. We have another question here. I don't know if you answered this one. This is a patient with a 2 months post-op rotation after surgery. Do you recommend to do laser corneal surgery or rotation of the IOL?
That's what I just that was the one that I answered before.
So you answered already this
question.
Okay.
Yes. There was someone here that talked that the technique, probably when I was talking about the reverse capture, would be tricky if the lens is a plate has a plate design, and I totally agree with you. Since my routine, like I don't use lenses that have a design like a plate, so it's not a problem for my techniques, but I can see how it would be tricky to optic reverse capture a lens that has a plate design.
No, it's possible to do it.
It's also possible?
Yeah, no, it's not possible. I think that
not possible.
Any models now, but I used to use the Star Surgical Play Haptic Toric lens back in the 1998. It was a very stable lens after they changed the model because they have two holes that were 0.7 millimeters to promote the fibrosis of the capsule and to prevent rotation. Then they still have some rotation. And some of these lenses, after you do capsulotomy, they drop into the nucleus, into the vitreous. Then they change the model and they increase the size of these holes. They had two holes and they increase the size to 1.1 millimeters. And with this, they decrease the possibility of rotation and the possibility of dropping into the vitreous after you do the capsulotomy. I don't know if there is many people using that lens or that technology right now. I haven't used them for many, many years. And haven't seen anyone after that using these lenses, or at least giving lectures regarding these Toric IOLs.
Mm-hmm. Yeah, so you, just to make sure, you said that it's not possible, right?
No, because it's a play haptic lens. It doesn't have optic like the one for a single piece lens. It's totally different.
Mm-hmm. Another question that came up, and it's very, very interesting, is the maximum cylinder that I correct at lens plane, especially with cases with such high astigmatism. I correct the maximum amount of astigmatism that's commercially available to correct in Brazil, let's say, which is 4.5 from the manufacturer that I use routinely now. But one concept that's very, very interesting is we can implant the toric IOL. Let's say the patient has 7 diopters of corneal astigmatism, and the maximum amount of astigmatism that I have available to correct is 4.5. So of course, this patient will have residual astigmatism that will come up in his or her refraction. One question, and some people can be in doubt, is, can I associate a relaxing incision to minimize even more this amount of astigmatism? And we have to be very careful. We can go follow this route, yes, but we have to first implant the toric IOL, wait for the surgery to heal, the cataract surgery, let's say, at least 3 weeks, 1 month, to make sure you have a stable refraction, and then plan your relaxing corneal incision based on your refraction, your postoperative refraction. Do not just consider that the amount of astigmatism that will end up is on the same alignment that it was preoperatively. It doesn't work that way. So you plan the surgery with the highest amount of field that you can correct with the toric IOL. You do the surgery, you wait for the eye to heal, at least 3 weeks, 1 month. And once you have a stable refraction, you base the planning of your relaxing incision on that stable refraction after cataract surgery. And it's interesting to see that many patients don't even see the need after you did the first surgery. They're so happy with the amount of astigmatism that you already corrected that most of the times you don't really need to go on the second step to do the relaxing incision. But if you do want to follow that way so that you can really have the minimum amount of astigmatism left possible, just wait so that your refraction is stable, and then you plan your relaxing incision based on that. One other question, is it possible that the IOL rotates many months after surgery, or the fibrosis should always keep it in place? I really haven't had any cases that rotated many months after surgery. What we really see, and from other colleagues' experience talking with different conversations, is that it usually rotates. If it's going to rotate, it usually rotates early on in the postoperative period. there's a one question on post-keratoplasty patients with the amount of astigmatism that we correct. So I usually correct the highest amount of astigmatism that's available commercially here, which is around 4.5. And then I do what I just explained with the relaxing incision, planning it after the refraction of that patient is stable. Remembering that the nomogram used in these patients with post-keratoplasty is very, very different than the ones that we use in patients with normal virgin corneas. Because in these patients with post-keratoplasty, the same amount, since we do it, the relaxing incision usually closest, let's say, to the center with a smaller diameter when compared to patients that have virgin corneas, the amount of astigmatism that's corrected is much bigger when we're talking about the same amount, the same length of relaxing incision. Louise is saying that we can correct up to 12 diopters of astigmatism with Zeiss double toric IOLs. Yeah, there are many different ones. I really, Zeiss lenses, I haven't used them, so I don't have experience with that.
Yeah, there are a couple of companies that could also customize the amount of astigmatism they can correct. You have Reiner from United Kingdom. They can customize up to 12 diopters.
Yes.
And there's another company in Germany, Human Optics. Human Optics can customize up to 15 diopters.
Yeah.
Yes.
Well, Jose Manuel, we have the privilege of having Dan Reinstein listening to us. He should be answering questions too here. I don't think this was very fair.
Where is he? I don't see him there. Let me see how I can find him. Let me see what I can find him.
So he's asking on relaxing incisions or less accurate than laser. So if I have a patient with very high astigmatism, like post-keratoplasty, if I would recommend the laser. It really depends on the patient then. But I usually, in the patients that I did have, that I combined, let's say, the maximum amount of Toric IOL that I had available with another procedure, I chose the relaxing incision based on the corneal thickness and different parameters. But you're right. There are some patients that are better off with correcting with the laser.
But if it was that high, then because of the inaccuracy, the relative inaccuracy of the relaxing incision, why not do the relaxing incision first, see how far you get, and then you'd have a more accurate result with your IOL.
Oh, that's a good rationale. I see where you're saying. I never thought of it that way. That's why we need very brilliant minds as yours. That's very, very interesting. Very interesting to think. So you're saying to do first the relaxing incision, see how much of it, based on then you would do it based on your measured corneal astigmatism. And then after, you would plan your cataract surgery based on what's left.
Well, you do the less,
is that what you're saying?
The less accurate procedure first.
Yeah.
The IOLs are pretty accurate.
The most accurate one is the toric lenses, for sure at this moment, because in the case of AKs and the limb relaxing incision, we have to account for the healing of the cornea, which is not the same in every single patient.
Yeah, but then what Dan's saying that we could do first the relaxing incision that's not so accurate, let's say, but then wait for the eye to heal and then plan our cataract surgery. That's a way to go,
but maybe I will think about that if I don't want to use a higher power lens, like the one that manufactured. If I have a patient that is above my limit, I might do something to correct the astigmatism that I think that I won't be able to correct with a single surgery, and I might do that. But if I have a patient within the limits that I can correct with the lens, why will I do an extra surgery if I can correct the astigmatism from the beginning?
No, but we're not talking about that. We're talking about cases where the astigmatism is too high for an IOL alone.
This is what I'm talking about.
And so, well, in which case, if you don't have access to laser and you only have access to incising the cornea or a lens, then you'd be doing the incisions first because they're the least accurate.
That will be a good point. That will be
The only thing about incisions, which I think many of us kind of overlook, is that not only are they very inaccurate, they're not stable. And so, you know, we forget that incisional keratotomy will continue to progress over time. So you might be very happy and discharge your patient at 6 months or 8 months going, wow, I got the astigmatism down from 6 to 1. This is wonderful. At 5 years later, they're at 3 diopters in the opposite axis because they've continued to flatten.
That's interesting. That's something interesting to look long term, because from my post PK, my post transplant eyes in which I have operated are few. We actually have, I usually send them to the cornea department and they usually take care of it when it's just like very high astigmatism and all. But the few that I did, I have like a follow-up of like 4 years. So it's not a very, very long follow-up, but in 4 years, they're pretty stable. It didn't really rotate a lot, but it's something that I will look up in the following years. Then that's something that's very interesting that you pointed it up. But as you said, and also Jose Manuel, the toric IOLs are much more accurate. So if we can use the toricity from the IOL to correct, of course, that's the number one choice. And I found it interesting while you guys were talking, I was looking at the chat and the other conversations, the amount of questions regarding long eyes and misalignment. And it's something that is an issue where when you're a cataract surgeon with high volume, you will get patients with long eyes and needing toric lenses. So it's something that's very interesting that we had the discussion on CTR, reverse optic capture. What's your opinion then on that? Do you do something routinely in these eyes to prevent rotation, or do you just do your normal surgery and if it rotates and then you do something?
I'm not an IOL expert like you, but I have access. Obviously, in our clinic, we are very adept with lasers, so we tend to not go inside the eye again if we don't have to, because it's so easy for us to adjust on the outside of the eye. I mean, we can do SMILE in a transplant, so and you can correct up to 6 diopters of astigmatism on the cornea very accurately with SMILE, and it's very and SMILE you really customize it to fit inside the inside the transplant. So it's kind of neat. I mean, one of the things I just posted there was, you know, if the astigmatism is that high that you can't even correct it with the Zeiss or a custom IOL that has 12 diopters of cylinder in it, now you're talking about 15 diopters of cylinder. Now you're talking about a real mismatch between the graft and the host. That's why there is so much cyl. And so that's when you might start considering graft rotation as a first step. It's an auto rotation. You take the same graft and turn it 90 degrees, because you might find that the recipient bed is summating with the graft's cyl, and you would greatly reduce the cylinder if you reverse the axes of the two.
Mm-hmm.
That's a good point.
I saw a case that patient had a graft, and she had MRIs and CT scans, and they thought that she'd had a stroke because her vision is 2200 and they couldn't correct it. It wasn't pinholable. And when we measured her with an accurate topographer, we found that she had 28 diopters of cylinder in her graft, which is why even a pinhole wasn't getting her good vision. She was an old lady. And a colleague of mine rotated her graft 15 degrees and she got her down to 12 diopters from 28. And then he sent her to me, and then I did a split axis excimer procedures. So I corrected 6 diopters of steepening and 6 diopters of flattening. So I actually did 12 diopters in the cornea, but not all of them in one axis. And we got her down to 20/30 vision uncorrected with a little bit of cylinder. So there's a sort of like a super extreme crazy case dealt with 2 super extreme crazy ways.
Yeah. Ernesto here is also commenting on graft rotation. He says, more so than graft rotation, you should do a wedge resection on the flattest axis. You can correct up to 10 to 12 diopters. Then once sutures are removed, more than 8 months, you do cataract and toric IOL for the residual astigmatism. It's so interesting how these patients post corneal transplant are like a world apart. Oh, there you are.
There I am. Sorry, I'm just coming out of the Ronnie Scott's here. Let the audience. So I'm sorry, guys. I got some work to do over here.
You should be staying home. That's why you have no audience. You're playing just for yourself.
Yeah, I sent the band home. This is way too interesting.
Guys, we still have 100 people here, which is fantastic. We have no time limit. Dr. Aldave apologized. He has an emergency and he's in the OR right now. So he asked for us to reschedule his lecture for April 28th. So we can still discussing here and answering some questions. So no time limit right now. And we still have more than 100 people on the chat. I don't know how many we have on YouTube, but we have 100 around now. So let's keep talking.
I think the SMILE question for Dan would be wonderful. Is there any paper you can point to regarding SMILE for post-keratoplasty astigmatism then?
I don't think that there is a paper on just that. I did a few cases when I started SMILE. That was the way I started SMILE, was in transplants actually. But there is a very, very, very exciting paper that just came out of the JRS. Jesper Hortal out of Denmark, who had a brilliant concept, which was to cut a high cylinder lenticule and then rotate it 90 degrees. Mm-hmm. And so right there, you have the cylinder.
Okay.
Very, very interesting concept.
Yeah.
You know, it's a little, it's like the graft rotation concept, but doing it kind of all with an, you know, you're cutting a cylinder and then putting it in the opposite axis. Very clever stuff.
Yeah, Nilva Royce is saying that she has experience in graft rotation, and it's true. She has been able to correct up to 20 diopters. Look at that.
Yeah.
Oh my gosh.
Yeah. But I mean, the reason why you have 20 diopters, you've got to ask yourself, is it because I'm a terrible graft surgeon? No, it usually isn't that. Usually it's because the cutting, the graft itself has additive to the host bed. And that's obviously, no one's measuring the keratometry of the graft donor or of the recipient. And you know, if we were, we would be orienting grafts if there was some kind of control of that sort. But yeah, that's right. You can correct huge amounts of astigmatism. By definition, the higher the astigmatism, the more likely there's a mismatch between the graft and the host.
Yeah, 20, that's amazing. It was interesting that some people asked before about the keratoconus and IOL indication. And if I looked at pupil size when I'm indicating a toric IOL in these cataract patients, and the answer is yes. I don't have a cutoff for pupil size, because we have to remember these cataract patients are usually older patients, so their pupil are usually smaller. But let's say you have a mydriasis, a patient that has a very big iris defect and a keratoconus, I would take that into consideration when implanting and planning the toric IOL. Here again, that's for you also, the laser person. If you're planning to correct residual astigmatism with laser after implanting IOL, will you aim for more myopia in your IOL? Well, that's a mix.
Well, no, Not at all. Is this from somebody who thinks that hyperopic corrections aren't very good on the cornea?
I don't know, but
Actually,
I never.
honestly, it depends on the aberrations that are already in the graft, because you know, generally speaking, uh, a hyperopic cylindrical correction takes tissue more from the periphery, right?
Mm-hmm.
And so, you know, often grafts, you don't know, some of these grafts can be quite thin because the donor was not a thick donor. So you need to, I don't know, I don't think there's a rule. I don't particularly worry about correcting up to 4 or 5 diopters of cylinder on the hyperopic or the myopic direction. I consider them to be pretty equivalent in terms of accuracy and efficacy. The advantage of the hyperopic cylinder is that you are myopicizing the cornea and vice versa. And you could be reducing a positive spherical aberration with one and reducing negative spherical aberration with the other. So yeah, I mean, I think looking at all the factors before you start would be the way you would plan it. But one of the things about cylindrical correction in keratoconus that's worth keeping in mind is that what you measure as cylinder in the cornea by topography in an asymmetric cornea is not necessarily accurate. In other words, the Ks, which is based on normal corneas, is an average of the 3 millimeter zone average curvature. And in a highly asymmetric cornea, the Ks might not represent the lower order astigmatism at all. What you may want to do in these cases is to get your corneal aberrometry and then separate the cylinder from the coma and look at the axis and the magnitude of the cylinder in the lower order readout of your wavefront. And I guess your limitation to where you might consider using a Toric IOL is the reason it's pupil related is because it's going to be to do with how much coma you're going to leave uncorrected on the cornea. And that could be debilitating. If you focus somebody very well with a ton of coma, you can make them quite debilitated.
Mm-hmm. Yeah, you have to take that all into consideration.
Yeah.
Yeah. Another question Mohammed sent is, do you undercorrect with the rule astigmatism and overcorrect against the rule astigmatism based on Baylor nomogram? When you use the Baylor nomogram for IOL planning, that's the rationale, that's the idea, yes. But when you're using, let's say, the Barry Toric calculator, the calculator is already embedded with the amount of corneal astigmatism, predicted posterior corneal astigmatism that you're going to incorporate in your calculation. So you don't have to think on overcorrecting or hypercorrecting. It's based on the, like I showed you on the slides, it already takes into consideration. It's another way of incorporating posterior corneal astigmatism. So avoid getting like 2 or 3 methods and then trying to put them all together. It's usually, they all have their rationale, and then you should choose what works best on your hands and then follow that. Toric IOL work when you want to leave the patient with monovision? Yes, because it works correcting the astigmatism. If when you're planning a monovision, it's very, very important to understand that you're planning to leave the eyes, let's say one emmetropic and the other with X amount of myopia. But if you leave an amount of astigmatism that's important in either eye, it will interfere a lot with the patient's quality of vision. So yes, you should plan on correcting the astigmatism of that patient the maximum amount if you could. And as to here saying, I agree, you should aim for metropia. You should obviously compensate for coupling, especially if the patient is plano in the sphere and the residual astigmatism is significant to induce flattening in the opposite meridian. So the amount of astigmatism, the most astigmatism that you can compensate in your surgery, if you're planning both eyes for metropia or one eye for metropia and the other eye for near, the amount of astigmatism, a residual astigmatism that you leave, if it's an important amount, it will interfere negatively with the patient's vision.
Okay, we can go for one more question, Bruna. I know you got things to do. You're pretty busy. So one more question.
So Dan, do you want to do your question?
Well, I wanted to ask you, have you explored, have you even digested the vector planning concept from Noel Alpins? Do you know what I'm talking about? I'm talking about,
yes.
about his concept of minimizing corneal astigmatism regardless of residual refractive astigmatism.
Oh no, then I'm not really sure I know what you're talking about.
Yeah, well, that's just because that's a whole other thing. Yeah, well, then forget it. I just wondered if you digested that, because I'm still struggling with it. And, since we're talking about astigmatism, it's a little bit more on the laser side, but it's this concept that if you have ocular residual astigmatism, let's say the cornea has 2 diopters of astigmatism on the Ks, and the manifest is 1 diopter in the same axis. That means that there's 1 diopter inside the eye. So he's saying, well, if you correct just 1 diopter according to the manifest refraction, you're leaving a diopter on the cornea. And even though the patient refracts plano, he says they're going to have visual disturbances because the cornea still has astigmatism. So he's saying you should correct 1.5 on the cornea, leave 1/2 on the cornea. And even though there's residual still in the manifest, the patient will see better. So this is like reading the rules as he's written them. And how much you leave inside and put on the outside varies from 60-40 to 50-50, whatever. But it's a concept which I don't understand. I just wondered if anybody else here can follow why that would be a good thing.
Yeah, no. But there's one question here that I think you could answer for the last one. How much you rotate the graft? Is it topo guided 180 or 369 degrees? You wanna?
Right. Okay. Well, when I was talking about that, I think I was talking about the idea of just making the assumption that if the cylinder is extremely high, let's say more than 10 diopters, if it is, then you probably have a graft host mismatch. I mean, unless it was the first graft of your first day of your first fellow who came in and let's just say you did a graft and you're pretty consistent, you get fairly good results, and suddenly, boom, you've got an eye that's just off the charts in residual astigmatism. You have to then assume that there's a graft host mismatch. And so how much you rotate it, well, I would say 90 degrees, because whatever the mismatch is, it's causing summation. So a 90 degree, well, at the worst case scenario, it causes subtraction, but I doubt it, but it would certainly reduce it. I hope that answers that question.
Yeah.
Okay,
I think so.
Okay. Well, Bruna, it was fantastic to have you here.
Great job.
For a beautiful lecture, fantastic job. And it also was great to see them.
It was.
I was lurking. I think I was lurking in the background, and I thought, well, let me throw a question in there. I didn't realize my name was on the damn question. Okay.
We already have your register here, so there is no way that you can hide in there.
Okay.
Yes.
Next time I'll know. Next time I'll know.
Oh. Well, thank you so much, Dr. Vargas. This was very interesting, and thank you, Dan, for joining us in the discussion. I'm sure it was very enriching. And I'm always open for anyone that wants to discuss something, or with my email. or Instagram accounts. Nowadays, everyone's so online and with social media, right? But it's this. Thank you so much for the invitation, and it's always a pleasure.
Thank you, Bruna. Thank you so much. It was an honor to have you here. And once again, the doors are open for you anytime. And thank you so much.
Congratulations.
Thank you.
Dan, I don't know if you want to add something or if you want to give us a surprise before we finish. But it was also a pleasure to have you here.
Well, thanks. No, just congratulations. It's a big subject. It's full of pit holes and traps. So yeah, you're mastering it very nicely. And thank you for sharing.
Thank you, then.
Great tips.
Thank you so much. Thank you so much. I love how we're all so connected with this, and we're all each one at home, but we're very connected, and technology is just fantastic.
Amazing.
Right.
Thank you, Bruna. Thank you, Dan. We really appreciate it. Thank you, everybody who attended the meeting. We will see everybody next week again. Thank you so much.
Okay.
We appreciate it.
Thank you.